Good evening, everyone. Welcome to the Designated Registered Nurse Prescribing Country webinar. We had our Metro webinar yesterday, and this one is for country, and it's an update and overview for general practice. Before we get started, I'd like to acknowledge and pay respect to the Whadjuk Noongar people upon whose land we are meeting. I honour their elders, past and present, and recognise the continuing connection of Aboriginal peoples to their lands, waters, and culture. I also recognise the diversity and strength of Aboriginal peoples and the significant importance of self-determination and cultural knowledge in supporting the positive health and well-being of the whole community. As this is a country webinar, I also acknowledge the lands upon which you are meeting as well. Just some general housekeeping. Your cameras and microphones are switched off, but I do encourage that if you do have a question, please pop it in the chat and we will answer it at the end of the webinar. And just to note that no AI note takers are permitted in here. And I'd love to introduce our speakers for tonight. We have Lisa Villay, Acting Chief Nursing and Midwifery Officer at the WA Department of Health, and Jill Law, who is the Acting Principal Nursing Advisor, also at the Department of Health. So I'll hand over to you now. Thank you.
Thank you, Michelle.
Hi, everybody, and thank you for joining Jill and I this evening to talk about designated registered nurse prescribing. We're really excited to be able to present this exciting new reform. We too would also like to acknowledge that Jill and I are meeting this evening on the lands of the Whadjuk people of the Noongar Nation, and we pay our respect to Aboriginal elders past, present and emerging, and also acknowledge that many of you may be dialing in from other lands. And we also acknowledge and welcome any Aboriginal people that may be joining us this evening. So I'll hand over to Jill, who is the fountain of all knowledge when it comes to designated registered nurse prescribing. As Michelle said, please feel free to drop questions into the chat as you go, and we'll do our very best at the end to answer. So thank you again and welcome.
Thank you, Lisa. Thank you, everyone, for joining us this evening. So what is designated registered nurse prescribing? So this is the most significant piece of reform within nursing since nurse practitioners 20 years ago. The journey to get to where we are today started about 10 years ago through multiple levels of consultation and work done with the Australian Chief Nursing and Midwifery Officers, along with the peak bodies of medical practitioners, the RACGP, APNA, and other interested professionals. So following all the discussions and consultations, in December 2024, the Health Ministers' meeting approved the registration standard to allow suitably experienced and qualified registered nurses to administer, obtain, possess, prescribe, supply, and or use Schedule 2, 3, 4, and 8 medicines in partnership with an authorised health practitioner under a prescribing agreement. And this registration standard by the Nursing and Midwifery Board of Australia came into effect on the 30th of September last year. So there's a few key components there within the standard. I'll just like to explain to you before we start. So it's a partnership model of prescribing. Designated registered nurse prescribers have to prescribe with an authorised health practitioner. That authorised health practitioner they need to work with, and they need to be an autonomous prescriber. So we'd see in most instances this will be a medical practitioner or a nurse practitioner, but it could also be an endorsed nurse, an endorsed midwife, podiatrist, an optometrist, any other profession with autonomy to prescribe. And the prescribing agreement is one of the key components within the clinical governance framework that is dictated by the registration standard that must be followed. So from the graphic that you'll see, we've got the prescribing agreement there in the centre, with the designated RN prescriber, the authorised health practitioner, and their employer. They're surrounded by rings of governance. So this is a safe model of care. It's safe for the patient. And the governance surrounding it also then provides protection for the designated RN prescriber, the health practitioner, and the employing organisation. So within your organisations and practices, you will have to look at your local policies, procedures, and clinical governance to ensure that that designated RN prescribers are able to prescribe within that. You need to follow the registration standard. There's also registration guidelines and a fact sheet that are available for people to look at to provide information. And as with everything, you need to work within the national and state or territory legislation and regulations. So there are multiple benefits to registered nurses being able to prescribe. To start with, it can eliminate unnecessary and delayed attendance for consumers, because many patients currently need to make additional appointments just to obtain or renew a prescription, even when their care needs are well understood. A designated RN prescribing can streamline these processes by enabling appropriate prescribing within a nurse-led model of care. This helps to reduce duplication, improves efficiency, and allows other areas of the health system to focus on patients with more complex needs. So it also supports improved quality and equity of care for patients, because at its core, designated RN prescribing is to improve patient outcomes by enabling nurses to work to their full scope of practice and provide timely access to safe medicines within established frameworks. This is particularly important for patients living in rural, remote, and underserved communities where access to a prescriber can be difficult with significant barriers. But by reducing these treatment delays, more equitable health outcomes can be supported regardless of where the patient lives. So it also improves access to affordable and quality health care. By designated RN prescribers being able to prescribe PBS medicines for patients closer to their home, rather than having to travel the long distances to see other prescribers. And this has particularly relevance to areas experiencing medical workforce shortages in rural and remote communities. It helps to reduce costs and delays with patients not having to access healthcare. Accessing healthcare can have significant travel costs, time away from work, and associated expenses. But designated RN prescribing can reduce these burdens and support more timely access to care, and reduces preventable hospitalizations by delaying access to medicines or interruptions to treatment, and which can result in deterioration in health and potentially avoidable hospital presentations. It also supports multidisciplinary working and strengthens coordination throughout care. Designated RN prescribing doesn't replace other health professions, and I think it's important to remember that. We're not trying to take work from anybody. This is an extra service through expanded scope of practice, and it strengthens multidisciplinary care. It allows nurses to contribute more effectively within collaborative healthcare teams, while maintaining clear referral pathways and communication with medical, pharmacy, and allied health colleagues, which can improve continuity of care and create a more seamless experience for patients. And lastly, it helps to align Australia with other international healthcare systems. Nurse prescribing is not new. It's been well established in a number of comparable countries, such as the United Kingdom, New Zealand, Canada, and parts of the United States. And this international experience has demonstrated through multiple pieces of research that nurse prescribing is safe, effective, and well accepted by patients. So implementing designated RN prescribing in Australia helps ensure our healthcare system continues to evolve in line with international practice. So there are multiple program dependencies that we need to consider for designated RN prescribing. Along the top, you'll see this is the nurse's journey. So for the nurse to become a designated RN prescriber, they need to complete the requirements for the endorsement, which includes a period of study. I'll talk more about the qualifications shortly. The qualifications are all approved by the Australian Nursing and Midwifery Advisory Council and the Nursing and Midwifery Board of Australia. So once you've sat that qualification, you can then apply for NMBA endorsement as a designated RN prescriber. Undergo local authorisation processes within your organisations that are consistent with the clinical governance mechanisms in place. You can then apply for a PBS prescriber number and real-time prescription monitoring system access. So just recently, the legislation has changed with PBS services, to allow designated RN prescribers to access PBS medicines. That was just approved at the start of this month. And once you've applied for your PBS prescriber number and have entered into a prescribing agreement with an authorised health practitioner, there's also a 6-month period of clinical mentorship that needs to be completed. So the prerequisites for the nurse journey, which are our dependencies, are the programmes of study that have been developed and made available and approved by ANMAC and the NMBA. There are currently 5 programmes of study in Australia that you can enrol within. There also needs to be clinical governance frameworks in place within your organisation. This includes the prescribing agreement, the clinical mentorship agreement, and the authorisation process, and any assurance and monitoring thereafter to ensure that the designated registered nurse prescribing is maintaining their endorsement. The legislative requirements that have needed to change, as I mentioned, were that the health legislation amendment for the prescribing of the pharmaceutical bills 2025, which has been passed through the Commonwealth Government at the start of this month, and it enables designated RN prescribers to prescribe PBS medicine listings. The Pharmaceutical Benefits Advisory Council have also met in May, and they've approved the first tranche of PBS medications for designated RN prescribers. Although we don't have visibility of what those medications are, we believe that it's a wide range. It's not until you actually have a PBS prescriber number that you can go in and see the exact medications. So Services Australia technology will be updated to generate designated RN prescriber numbers from the 1st of October this year. And real-time prescription monitoring, so in WA, that's Script Check WA, that will be updated by the end of this month, so you'll be able to apply for access. And this is necessary when you're prescribing Schedule 8 medicines. It's a mandatory requirement when prescribing Schedule 8 medications that you check on Script Check WA. And in line with that, with WA, our jurisdictional legislation and regulation changes that need to be made was changes to our Medicines and Poisons regulation. The Medicines and Poisons Act already authorised nurses to prescribe, but the regulations were the barrier. So there has been lots of consultation on the regulations. This has all been approved. The recommendations have been sent to the Minister who has approved these, and they're currently sitting with the legal and draft writers. And we're hoping that that will all come into place by the 1st of October and be passed through Parliament. You would also need to look at your local digital systems if anything needed updating to include designated RN prescribers. So within WA Health, for example, our SIMS, so our Clinical Incident Management System, will be updated to include designated RN prescribers as a workforce group. And you'll also need to look at your authorised health practitioner and identify them. So within the communities that you're working within, that will most likely be a general practitioner or a nurse practitioner. So the national governance, as you would think with any pieces of national reform, there's lots of governance there within. If I start along the bottom blue line there, we've got the Australian Nursing and Midwifery Advisory Council, who have looked over the education providers and are assessing all the qualifications that are being presented to them. We have the Nursing and Midwifery Board of Australia, who have developed the standard, the guidelines and the fact sheets. They will be maintaining this and the reviewing. And I think there's already a review of the guidelines in place. And we also have the jurisdictions who are working together. And this includes the Australian Chief Nursing and Midwifery Officers from each state and territory, as well as their principal nursing advisors, who are part of a jurisdictional leads group. Together, they work together as the Implementation Oversight Group, which is chaired by the Commonwealth Chief Nursing and Midwifery Officer. We call that the IOG. So the IOG reports up to the Health Workforce Task Force, and they do this monthly, who then have to report up through the Health Chief Executives Forum and up to the Health Ministers meeting. Within WA Health, we also have our layers of governance that we have to work within. We have a project team working on designated RN prescribing. So myself is the lead, Catherine Barrett's our project manager, and I have 2 project assistants, Margaret Adejuma and Alison Wingrove. We report up to the Chief Nursing and Midwifery Officer, who is Annie Thompson, and that's our executive sponsor. And then every change that we need to do and following closely with the work that we're doing is our Health Executive Committee, which is the workforce stream. We then report up to the Director General, who reports up to the Implementation Oversight Group and onto the Health Workforce Task Force. So individuals as well have key governance responsibilities. I've mentioned some of these as we've talked through already. So the NMBA has set the standard and the competencies. They approve the education pathways together with the Australian Nursing and Midwifery Accreditation Council. They have full oversight of the regulatory components, and they will endorse all the registered nurses who have undertaken the required education and meet other eligibility criteria. Your employing organisation needs to have that clinical governance and oversight within their area. This includes ensuring that everything for the clinical governance framework is in place, including the prescribing agreement and the clinical mentorship agreement. These are the two key documents you'll hear me talk about, and I'll give you examples of them shortly. Your employing organisation also needs to ensure that all policies and safety systems have been adjusted and adapted where needed to include designated RN prescribing. And as I said, that prescribing agreement in place. With the authorised health practitioners, they have clinical oversight of their patients and of the designated RN prescriber. Their prime responsibility is for consultation and support of the designated RN prescriber. They may also be asked to participate in audits. That might be through the organisation themselves, or they may be called upon by the NMBA to produce prescribing agreement documents. So the designated RN prescriber, ultimately, the registered nurse prescriber has individual accountability and responsibility for every prescription that they write. They have to prescribe within their scope of practice, their model of care, and their context of practice. They need to maintain their competence and the extra 10 hours of continuing professional development each year to maintain their endorsement. This extra 10 hours of CPD has to be related to prescribing. This is consistent with endorsed midwives and with nurse practitioners who also hold an endorsement for prescribing. And they need to follow any legislation and policy, and that's not just within the state and territory in their workplace, that's also all legislation and policy within the Nursing and Midwifery Board with your practice standards. So how do you become a designated RN prescriber? So your registered nurse needs to hold general registration with the Nursing and Midwifery Board of Australia with no conditions or undertakings on that registration. They need to have 3 years of full-time clinical experience or equivalent within the past 3 years. So within the past 6 years. This equates to around 5,000 hours. They need to complete their NMBA approved units of study, which is at an AQF level 8, which is a graduate certificate or graduate diploma level, or equivalent units of study. Now, this may be study that's been undertaken overseas that is equivalent, or it may be just a couple of units within the graduate certificate or graduate diploma. They need to then apply for endorsement by the NMBA for your scheduled medicines, at which point you can apply for a prescriber number with Services Australia and apply for access to the real-time prescription monitoring system. At all times, as I've said, you had to ensure compliance with the NMBA standard and guidelines, the policies and legislation of your state and territory, your employer, and health service. And this includes the quality use of medicines principles and the NMBA standards, codes, and guidelines. And then work within your agreed clinical governance framework with your authorised health practitioner as your prescribing partner under an active prescribing agreement and a 6-month period of clinical mentorship. This is a matrix that we've put together just to show the differences between prescribing between a registered nurse, a designated RN prescriber, and a nurse practitioner. It's extremely important that designated RN prescribers don't get conflated with a nurse practitioner and aren't asked to do something that's out with their scope and capability that may put them and their patients at risk. So the differences are that your registered nurse is qualified to an AQF 7, so a bachelor degree, or a master's direct entry. They don't have to have any previous experience prior to registration. whereas your designated RN prescriber needs to be qualified to that AQF Level 8 graduate certificate or diploma and have done 5,000 hours of post-initial registration clinical experience. And your nurse practitioner, on the other hand, has to do an AQF Level 9 master's degree, and they have to do 5,000 hours at an advanced practice level, and that's generally once you reach the CNC/CNS level. So registered nurse doesn't hold an endorsement, whereas your designated RN prescriber and your nurse practitioner do. They're different endorsements. And the scope of prescribing. So registered nurses can administer medicines prescribed by an authorised health practitioner, and they can supply medicines via approved standard protocol and policies, which in WA we have our structured administration and supply arrangements or SASA agreements in place. Your designated RN prescriber will be able to access and prescribe Schedule 2, 3, 4, and 8 medicines for a limited range of condition within their model of care, scope of practice, and context. This must be done, again, I'll repeat it because it's very clear and needs to be remembered, in partnership with an authorised health practitioner and under a formal prescribing agreement. Whereas your nurse practitioner can practice autonomously, and they can also diagnose and prescribe Schedule 2, 3, 4, and 8 medicines within their defined scope of practice. So it's important to remember that your designated RN prescriber is not able to diagnose. It's not within their scope of practice. So for your prescribing authority, your registered nurse has no independent prescribing authority. The designated RN prescriber does have authority to prescribe those Schedule 2, 3, 4, and 8 medicines under their prescribing agreement. And whereas your nurse practitioner has full independent prescribing rights for Schedule 2, 3, 4, and 8 medicines. So our progress within WA Health, we've been working on this project now for just over a year. We've come a long way in that time, and we've understood the model a lot more from when we first started. And we're currently actively seeking early adopters. So anywhere who has somebody who's interested in becoming a designated RN prescriber, has the support of their organisation, and has an authorised health practitioner willing to support them. So we're looking forward to having early adopters come together as part of our WA Health Designated RN Prescriber Project Control Group. We've also implemented a Designated RN Prescriber Advisory Committee. This committee has been meeting now for almost a year. We have broad representation from WA Health, from our private sectors, from primary care. We've also got representation from peak bodies, from our ACNP and the ANPA. As well as representatives from Justice Health. We've got a community representative and Aboriginal Health. We have a detailed communication and stakeholder engagement plan with a designated shared email. So we would encourage anybody who needs any further information or would like to ask questions, if not tonight, you can think of something at a later date, to please drop us a line through our email inbox and this will be addressed. We do have a dedicated web page which has lots of information on it and is updated monthly with the implementation oversight group minutes and updates of what we'll be doing in WA Health. We also have put out social media posts. We communicate through HealthPoint emails, through media statements when required, and through forums such as this. As I mentioned, the WA Medicines and Poisons Regulations 2016 are currently, the new amendments to that are being drafted, and we hope to have that through Parliament by the 1st of October. With the Implementation Oversight Group, the jurisdictional leads have developed a national template for the prescribing agreement and the clinical mentorship agreement. These have been through extensive consultation with peak bodies, and the feedback was all taken on board, looked at, and the documents adjusted, and these have been approved and endorsed by the Implementation Oversight Group. They've also been endorsed with WA through our Director General. They're currently sitting with our comms group, and they'll be posted online through our webpage shortly. To support these documents, which are extremely high level, we have developed the prescribing guidelines and a mentorship framework. These have also been consulted on broadly and widely, and the amendments have been made and they're currently waiting to be endorsed. So, and also we've developed a policy. So an authorization, monitoring and assurance policy with guidelines that are going to sit underneath these. All these documents will be on our webpage, so anybody's free to have a look at them, to use them, adapt them to their context. Within our implementation toolkit, these documents will sit along with some examples and a suite of vignettes with example prescribing agreements. So this prescribing agreement that I've talked a lot about, it's a formal written agreement between the designated RN prescriber, their authorised health practitioner and their employer. It details the roles and responsibilities of all parties. It provides the scope of practice of the designated RN prescribing, the medical conditions and the medicines that they're going to be authorised to prescribe in partnership with their authorised prescriber, any processes for consultation and referral, should there be deterioration in the patient or changes in the patient's condition, and they feel that they cannot make the changes required to the prescribing without consulting. There's individual arrangements for when there's multiple authorised health practitioners. So it has been realised that especially in rural and remote areas, there may not always be a consistent authorised health practitioner available. So there is that availability to be in prescribing partnership with one or more authorised health practitioners. There's also space there to document your process for resolving or escalating differences of opinions and for monitoring and audit of designated RN prescribing. The prescribing agreement needs to be reviewed and updated every 12 months. And this is a mandatory component within the clinical governance framework set out by the NMBA. And all signatures and approvals need to be within it. So the next few slides are just showing you what this prescribing agreement is going to look like. So there's lots of space there for you to put the designated RN prescriber name, title, endorsement details, employer number where applicable, who the authorised health practitioners are going to be, to include their name, title, role, registration, the review date of their prescribing agreement, the name and address of your organisation, and the clinical service within which you work. There also needs to be here documented your clinical service director or equivalent and your line manager. Now, while this document says that your line manager is optional, we would recommend that your line manager is included here to have oversight of designated RN prescriber and their prescribing. And then you would document your clinical mentorship details. The next section is about scope of practice. So any postgraduate education and training that are relevant to designated prescribing role. Now, this will include the graduate certificate or diploma or units of study that you've undertaken to become a registered nurse prescriber, but it also includes any other qualifications that you've taken within your specialty area. And then there's a section to detail your scope of practice, and this will be individual to each person. So you look at where you're providing care, with whom and how, and you prescribe your scheduled medicines. So there's a list there just of documents that you may find useful that are there within your general prescribing guidance that you can look at times if needed. Then moves on to look at the authorised medical conditions and indications for which the designated RN prescribing can prescribe or de-prescribe or continue medications. And then the authorised medicines. So we've just asked there for the medicines therapeutic class. They don't necessarily need to document each individual medicine because that list could be quite exhaustive. And you indicate whether it's a new prescription can be undertaken, whether it's continuing therapy only, or whether the designated RN prescribing can cease drugs. And if there's any exclusions within that medication class. And there's a separate section for Schedule 8 medicines. And again, what conditions and indications there may be, and any exclusions and limitations. Noting at the bottom there that you need to have real-time prescription monitoring in place to be able to access and check. And this is what I talked about, the escalation processes you would put in place for any clinical escalation that was required, any clinical dispute resolutions or professional dispute resolutions, and your safety and quality governance processes to monitor safe prescribing. The last place is the page is the agreement, which is signed by your registered nurse and their authorised health practitioner to ensure that they've discussed all aspects of the prescribing model and that they agree on what the designated RN prescriber's scope of practice is going to be, the medicines that they prescribe for, and the medical conditions. So the other document I've talked about that's mandatory is a clinical mentorship agreement. So it's necessary for every designated RN prescriber to undertake a 6-month period of clinical mentorship upon endorsement. It's also necessary if the designated RN prescriber were to change roles, to change their model of care, or to change their scope of practice, that they need to enter into a new clinical mentorship agreement and a new prescribing agreement. So while this says that it's for a period of 6 months, should the designated RN prescriber or their mentor consider that it's worthwhile to continue that mentoring period for longer, then that's perfectly acceptable. It just can't be shorter than the 6-month period. So the clinical mentorship agreement outlines the framework for mentoring, including defining the expectations, boundaries, roles and responsibilities and communication methods. It requires the signatures and approvals from the designated RN prescriber, their authorised health practitioner as their mentor, and this can be a different authorised health practitioner to who they're in a prescribing agreement with. The line manager, the clinical lead, and the professional reporting line must also sign this document. And it's important to note that clinical mentorship, it's not clinical supervision and it's not performance management. It's a relationship between the designated RN prescribing and the clinical mentor to consolidate their knowledge and their skills and to build confidence in prescribing. So this is the clinical mentorship agreement. It's a very high-level document. There's not an awful lot of detail there within it, which is why we've developed our mentorship framework. So within our mentorship framework, we provide you there examples of mentorship tools. We have recommended the iGrow mentorship model. We also have examples there of reflection, question and reflective practice that may be used as part of a mentorship meetings. And it's recommended here within the agreement that the mentor and the mentee meet at least monthly. There's nothing within the NMBE standard that details how frequently the mentor and the mentee should meet, but we consider to get the most out of this and to learn and improve skills and knowledge and confidence that a monthly meeting occurs. So programs and scholarships, as I mentioned, there's 5 accredited programs in Australia. So within WA, Edith Cowan University has been accredited for their graduate certificate in registered nurse prescribing. This course starts next week and they've had great intake. I think they're almost at capacity, which is 100 students. You can also study at La Trobe, the University of Melbourne, Queensland University of Technology and the University of Tasmania. There are differences between all these courses. So the University of Melbourne just offers micro-credentialed units. So if you want to just do 2 units to gain your endorsement, this can be offered by the University of Melbourne. But I would consider that the units here are $7,000 as opposed to ECU, where it's Commonwealth supported. So if you're looking to undertake a course, do research carefully the universities that you're considering. So the Chief Nursing and Midwifery Office has entered into a collaboration with ECU, and we're going to support 80 students over 4 semesters with a full scholarship to obtain the qualification. However, there's also scholarships available through the Australian government, which are being administered by the Australian College of Nurse Practitioners. And these are essentially for primary care, nursing and midwifery applicants, and also those within the aged care. And again, these scholarships are fully funded. So this is just detailing what we have within our toolbox. I've talked about most of this, as well as everything I've mentioned. We do have frequently asked questions, and we're developing a consumer fact sheet. So for your individual health service or organisation, what do you need to be considering? So you need to be considering your clinical governance framework. So safety and quality mechanisms, what do you have in place that's going to monitor the safety and quality of prescribing by the designated RN prescriber? How can you capture this within any incident adverse event reporting? How are you going to audit it? and address any adverse events. So by monitoring and reviewing prescribing of the designated RN prescribing, as mentioned, you need to look at policies if they need to be reviewed and amended, and what monitoring and assurance do you have in place to ensure that the designated RN prescribing is maintaining their endorsement and that the prescribing agreement is being renewed every 12 months. When implementing designated RN prescribing, it's important to look at your strategically. So what are your service needs within your area? Where are there gaps in care that a designated RN prescriber can add value and add benefit to the patient and improve access to care for patients? You need to look closely at your change management plan, how you're going to communicate these changes across your organisation, and any training activities that may need to be considered. And this would include offering education or opportunities for your designated RN prescriber to undertake those extra 10 hours of CPD that are a requirement for their endorsement. And looking at any implementation support that may be needed for the designated RN prescriber and their authorised health practitioner. So as with the introduction of any change, there are multiple system risks. So we've identified many when we commenced this project. When we commenced, lots of them were high risk. We now are happy to say that we've been able to reduce that risk category almost as we've worked through. So we now know that we have a lot of stakeholder engagement and participation, so far more than we had a year ago. We do have an engagement from medicine pharmacists and our nurse practitioners, and we have limited resistance to reform now. There will be challenges with the prescribing partnership and mentorship engagement. We do know that will be a challenge for many areas. So it is a risk that we've identified, and probably within your organisations would need to be identified as well. To begin with, there was no education courses accredited, so we're very grateful now that we've got 5 courses and more coming in the wings. We were never sure when the Commonwealth and state legislative regulatory amendments would pass, and we're very hopeful for October. So we're very glad that the Commonwealth amendments have been made and passed. And as I say, we're still hopeful in WA that we'll be ready to go by the 1st of October here. One of the other big things that we have had to consider is indemnity insurance for the designated RN prescriber and the authorised health practitioner. We are aware that within the WA health service providers and within the big private hospitals, that the nurses and doctors are covered under the insurance already in place. So this would just be a conversation that any registered nurses or authorised health practitioners would need to look at their organisation and the area within which they work to see if the insurance would cover this model of care or whether you need to get individual indemnity insurance. I talked about the differences between the RN, the designated RN prescriber, and the MP roles. This is a risk that we hope never eventuates, but there could be a risk between the conflation of prescribing between the roles. It has been mentioned a lot, and I know that there's lots of questions around remuneration associated with designated RN prescribing. At this stage, there's no extra remuneration for those who undertake the prescribing course and gain their endorsement. If you work within WA Health and don't already have a qualification allowance, you will be eligible for that if you've undertaken a full graduate certificate or graduate diploma. And the awards under which you work, there may also be scope there for qualification allowances. You would have to investigate that. We would hope that there's no locally imposed restrictions to designated RN prescribing, but we're aware that this may be a risk and there may be artificial barriers put up into place. And there's also a risk if your implementation approach is not strategic and service driven, then we might end up with designated RN prescribers who are unable to prescribe because their area that they work within their organisation does not have someone who can be their authorised health practitioner or a model of care within which they can prescribe. And we, as I keep saying, we're hoping for a go-live date early October. So in summary, strong governance is essential. I hope that's been made very clear. You need to work within that clinical governance framework. There needs to be clear authorisation, mentoring and policy frameworks because these will underpin the success of the model. You need to have risk mitigation and quality assurance embedded from the start of the project. By identifying and embedding this from the start, then there's more promise for your project moving forward, and that designated RM prescribing will be accepted. And you need to ensure that there's sustainability and continuous improvement. That's the end of the presentation. Thank you for listening.
Thanks, Jill and Lisa. We'll move on to questions now. We just had a few questions submitted. So the first question is there an understanding that MBS item numbers will be made available to the nurse prescriber in a GP setting once they are registered?
Sorry, yes, I was answering this one. So currently there's no established MBS items set for designated RM prescribers. The current focus has been on getting the PBS access, so that is to enable PBS prescribing, but that is something that we're definitely moving towards, but is not available just yet.
Thank you. Another question was, I'm already a qualified remote area nurse and have been practicing for many years in the primary healthcare settings in remote Aboriginal communities. I have all of my RAN qualifications as well as a master degree. Will these qualifications be recognised in this new primary healthcare setting in Perth as opposed to only being recognised at designated nursing posts in rural and Aboriginal communities remote?
Thanks, Michelle. And that's a really good question. Really, the answer kind of depends. So it depends whether the new employer in Perth would recognise those existing qualifications, and some expanded practice authorities that would apply in designated remote nursing posts may not automatically transfer. And that would depend on the local governance arrangements, the employer requirements, and legislative and endorsement framework set up. In relation to designated RN prescribing, the experience gained as a remote access nurse is highly relevant to the clinical hours required for endorsement as a designated RN prescriber. But to become a designated RN prescriber, you also have to complete that ANMAC qualification, which is an NMBA approved course that leads to qualification. So it really does depend on the employer and what they will recognise to support that model.
Yeah. To follow up that question, in relation to the RAN question, could RPL be applied?
So again, that would be a question for the applicant who is undertaking that program of study. So that will depend on what that university would recognise as units gained or credited towards RPL.
Yeah, thank you. A third question is, would or could this be used in a correction setting?
Yes, 100%. So really wherever there are registered nurses working and they have the appropriate governance and support and access to the authorised, said it 1,000 times.
Health practitioner.
Thank you, authorised health practitioner. This model can be set up, and that might be a really good place for this model to work, where there may be limited access to other authorised health prescribers. So yes, 100%.
Thank you. Are any postgrad qualifications necessary aside from the prescribing endorsement PG, or does clinical experience suffice?
Yeah, there's no other qualifications are required other than the designated RN prescribing qualifications through ANMAC and the NMBA. So that graduate certificate, graduate diploma, or the 2 units that are offered on prescribing. So once you have obtained them and you have the 5,000 hours of clinical practice, you can apply for endorsement through the NMBA.
Thank you. We've got another 2 questions that are quite similar. So will the authorised health practitioner need to be on site when the RM prescriber prescribes?
No, they don't need to be physically on site at the time. They need to be within the agreement. They need to be able to be contacted should there be a change in condition of the patient, or somebody else within the hospital or area within your work, which is primary care, which is why we see sometimes you might have that need to have more than one authorised health practitioner on that prescribing agreement. So they don't need to be on site at the time. They need to have a close relationship with the designated RN prescriber and have filled in the prescribing agreement so that both parties are clear on the medical conditions that they can prescribe for and the medicines that that involves. However, it's very important to remember that should there be any changes in the patient's care, especially if it's deteriorating care, that any policies and procedures are followed along that line, and to remember that your designated RN prescriber is not able to diagnose.
Thank you. We've got another question that's similar. Does the authorised health practitioner have to be employed at the same organisation? So if an RN prescriber works for a community nursing organisation, can their mentor work at a local GP practice?
That's a great question, and I'm going to take that one on notice, if I may, and find out that precise answer for you, because there's still some areas where we're working things out. So I'll take that one on notice and I can get back to you, please.
Thank you. We can address that one in the post-webinar email that we'll send out, and when we get the answer, we'll send it through then. And I think that's the end of the question. So thank you, Jill. Thank you, Lisa, for your time tonight. Does anyone have any more questions that they'd like to pop through? If not, then please use this feedback form. There is a section where you can pop your questions in. You can also use this feedback form to leave feedback for our lovely presenters tonight and share anything else that you'd like to share with us. Oh, sorry, I've got someone. Thank you so much, Jill and Lisa. And thank you everyone for taking the time tonight to attend this webinar. We hope it was valuable and useful. We will send out the slide deck and the recording of the webinar to everyone after this webinar, as well as the answer to the question. Thank you, everyone, and I'll end the meeting now. Have a good night.
Thank you. Bye-bye.
Thank you.